a focal enhancing mass with surrounding edema and a lot of mass effect in this 8-year-old boy from the North Coast with the antecedent of chronic otitis. He has a history of bathing in cylinders with standing water. And this is other case where we see many focal lesions in both temporal lobe, more in the left side, with ring enhancing surrounding edema and mass effect. This was a 28-year-old male from Lima who suffered from discomfort, severe headache, nausea, and vomiting. He was a surgeon of the Navy who was training in command actions and continually exposed to marshes and lagoon. In the cases of all the series, stereotaxis biopsy was performed. In this case, the 8-year-old boy, the biopsy revealed diagnosis of amoebic encephalitis. And in the second case, the surgeon of the Navy, the initial biopsy revealed that it was a glioma. But after the patient dies, the autopsy revealed that it was amoebic encephalitis. All the patients from this area died within 15 days to arrival to the institution. Now, I would like to show this case of a 21-year-old woman, and this MRI that was obtained 7 days after the onset of neurological symptoms. This was on June 2007. We see a focal enhancing lesion with surrounding edema. Well, looking in the research history, it was found that on February 2006, the patient had a cutaneous lesion on the knee showing violaceous and papular lesion, as you can see here in the image. And the biopsy at that time revealed amoebic trophozoite. The patient received prolonged treatment with the combination of 3 drugs. And after the start of the treatment, we see 1 week the process of healing in the skin of the knee, and the MRI 5 months after the start of the treatment show no evidence of contrast-enhancing lesions. 4 months after the completion of the treatment, the image shows the disappearance of the brain lesion, and on May 2008, on the follow-up of we can see here the healed knee lesions. This case is one of the few cases reported in the world successfully treated for amoebic encephalitis. There has been around 7 survival cases that have been reported in the world, and 3 of them were in Peru, as you can see here. Now I want to show a different case. In this 78-year-old male patient with type 2 diabetes mellitus and ketoacidosis with swelling of the right side of the face, right facial paralysis, ptosis, and a necrotic ulcer in the right palate. We can see here on the coronal MRI inflammatory compromise of the right maxillar sinus, of the orbit, and an abscess that was forming in the right frontal lobe. Culture secretion revealed aspergillosis fumigatus, and the biopsy of the palate and ethmoid bone was consistent with mucormucosis. The diagnosis was co-infection of mucormucosis and aspergillosis. Mucormucosis and aspergillosis are the most frequent fungal infection caused by filamentous fungi, but the co-infection in the same host is rare. Now I would like to present these 2 cases of 2 young males who present with multiple hypointense T2 lesions. In the first case, we can see that the lesions are located in the frontal, parietal, and occipital lobe. And in the second case, the lesions were located in the basal ganglia. After the administration of contrast, we can see ring enhancing and vasogenic edema and mass effect, as we can see here in the first case. Both of the patients had a history of HIV. And the final diagnosis in these cases were toxoplasmosis. So every time we see a T2 hypointense lesion, we have to include lymphoma and sometimes tuberculosis in the differential radiological diagnosis. And this is the final case of a 32-year-old male patient with HIV when we see isointense lesion in FLAIR and T2 in the left parietal lobe with surrounding edema, and after the administration of contrast, we can see that there is a lot of enhancement. Diffusion-weighted imaging shows restriction of the diffusion, and the ADC map shows low value. So we thought this could be maybe a lymphoma or a neoformative mass, but the perfusion image shows low perfusion in the relative cerebral blood volume, and the final diagnosis was also toxoplasmosis. Well, when dealing with suspected CNS infection, in addition to the radiological information, we need to take into consideration the following guidelines. Here, I have some take-home message for us to look at. First, it's very important to look for the clinical history. We have to ask for the patient for recent travel to endemic areas, high-risk behavior, and occupation. Also, we need information regarding geographic location and knowledge about endemic diseases. We need to know about the immune status of the patient. We need information about the serology, CSF, and if there is a biopsy and if we have correlation with this finding. And of course, we have to look for our radiological appearance or our radiological signs. We have to look for the signal intensity of the lesion, for ring-enhancing lesion, for mass-like lesion. We have to look for signs of meningitis and symmetric deep-gray nuclei lesions. And of course, if there is available, we have to look for the information that we can get for advanced neuroimaging techniques. Finally, I want to share a nice cultural aspect of Peru, and this is our traditional dance called marinera. I am proud to show you this photo of my daughter performing our national dance, la marinera. Muchas gracias. Thank you for your attention.